and management of difficult to control eczema. My name is Amy Dow, and I'm the Director of Education Programs for the Asthma and Allergy Foundation of America, the New England chapter. AFA New England is a 501c3 nonprofit organization dedicated to improving the quality of life for people with asthma and allergies in the 6 New England states. We pursue this mission through a wide range of education, public awareness, advocacy programs, and support for research. The speaker series was developed by AFA New England to be a source of timely, valuable, and vetted information for our constituents, patients, and families dealing with the impacts of asthma and allergies. Our 2021 Spring and Fall speaker series are sponsored by GlaxoSmithKline. So thank you to GSK for your generous support and participation in this endeavor. Tonight's event is being recorded and will be available for future viewing on our website at asthmaandallergies.org. We ask that all participants remain on mute during the event. There will be time for live questions with Dr. Scott, and at that time, please feel free to unmute. You can also ask questions via the chat function at any time, and Dr. Scott may break into the talk or hold your questions until the end of the presentation. We will attempt to field as many questions as we can in the 1 hour time that we have allotted for the speaker series event. Before we begin, one brief disclaimer. Any mention or reference to a company, institution, or organization or its available products or services should not be construed as an endorsement or recommendation by AFA New England. Information presented should not be used as a substitute for responsible professional care to diagnose and treat specific symptoms and illnesses. AFA New England will not be held responsible for any actions taken by attendees or viewers as a result of this speaker series talk. Thank you. I am pleased to introduce our guest speaker tonight. Dr. Jordan Scott is a lifelong resident of Massachusetts. He graduated from Boston University Medical School in 2000. After completing a residency in pediatrics at UMass Memorial, he trained in allergy immunology at Boston Children's Hospital with adult training at Brigham and Women's Hospital. In 2006, just after completing his training, he acquired the allergy practice of Dr. Geraldine Feldman, forming Northeast Allergy, Asthma, and Immunology. Dr. Scott takes pride in training future physicians. Dr. Scott is a clinical instructor in community medicine for the UMass Memorial Family Practice Program in Worcester. Dr. Scott is a board certified in allergy immunology. He is a member of the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, the New England Allergy Society, and is the president of the Massachusetts Allergy and Asthma Society. I am very pleased to turn the program over to Dr. Scott for his presentation on the evaluation and management of difficult to control eczema.
Thank you, Amy, and thank you everybody for your time this evening. Hope everyone's hanging in there, especially with all the tree pollen this past week. For those of you who suffer from spring pollen allergies, this is a topic that we saw a lot of, during my training at Boston Children's. We saw some really difficult cases from at times all over the world. Sometimes patients had to be admitted to the hospital for even a week or two at a time just to get their eczema under control. So my last 20 years or so in practice, we've seen a lot of tough situations, and I'm glad to see that in the last 20 years we've had a lot of advances as well. So here's some of my disclosures. I'm involved in a couple startup companies, involved in food allergen detection and also a new type of epinephrine auto-injector. And then I'm also on a board for another physician organization where we work with some managed care committees. And for my practices, I have 5 allergy practices throughout Massachusetts where we see adults and children. Now, so what is eczema or atopic dermatitis? Sometimes it can be a little tricky to define, but basically it's considered an itch that rashes. It's chronic, it comes and goes. From an immune standpoint, it's T-cell mediated. There's problems with your skin barrier as well, where a lot of people with eczema, they'll lose water from their skin to a faster degree. They'll have a breakdown basically of their skin barrier, which is why it's itchy and dry. And the more one itches and scratches, the more it itches and the vicious cycle continues. Sometimes it can be triggered by allergies, but not always. And very often it presents in early childhood, but not always. Sometimes it may not present, until adulthood. So who gets it? Family history is a big factor. In my practices, we see a lot of multi-generations. I guess I'm old enough now where I'm starting to see grandparents, parents, and children. And so 80%, with a family history of allergies, that's a lot of people who tend to get it. Again, most are diagnosed by age 5. If both parents have it, very likely the child will get it. If the condition's mild in childhood, it usually tends to resolve by age 3. And then if it's moderate to severe, more than half, it'll tend to persist into adulthood. So with not treating it, what can happen? Well, it can be extremely stressful. Sleep deprivation is a huge factor. I mean, the difficulties with sleep from chronic itching is very real. Oftentimes when we've had to admit people to the hospital, it gets that severe. Just the sleep deprivation is such a huge factor. We'll have parents who haven't slept, because their child's up scratching all night, or, adult patients who haven't been able to sleep days, sometimes weeks. This can be very depressing, very isolating. I've had teenage patients whose facial eczema can be so disfiguring they don't want to go to school. There's also the risk of developing food allergies. There's been a lot of studies where when your skin barrier is disrupted, you're at greater risk for developing food allergies. And one of the big causes they think behind why we're seeing more food allergies is with increased eczema and skin barrier disruption. If you get the allergen exposure through the skin, when you're sensitized through the skin, you're more likely to develop an allergic response rather than the usual methods of getting tolerance through the GI tract. With eczema, people tend to have a greater risk of developing asthma and nasal allergies later in life. Also, scarring of the skin from chronic scratching, chronic thickening of the skin. Secondary skin infections can be a big problem we'll see as well, especially with herpes, staph. Staph is a huge problem we'll see in the community. Years back, MRSA just used to be in the hospitals. Now it's all over the community. Then there's other viral skin infections such as molluscum, and even skin cancer, again, from skin barrier disruption and chronic scratching. So to diagnose, they're technically in the dermatology literature, there's major criteria, minor criteria. They talk about age appropriate distribution, where with infants and toddlers, it tends to be on the face, while for children and adults, it tends to be in flexural areas like in the creases of your elbows or behind your knees. So the distribution is very important in terms of helping to diagnose it. And again, family history is very important, and it has to be chronic and itchy. And then there's a whole bunch of minor criteria I can go into that can be associated with eczema as well. In terms of the differential, especially for our severe cases, this is extremely important because a lot of conditions can mimic eczema. And for sometimes a lot of our consults, when we've been opinion 3, opinion 4, we have to be sure to think, what else could this be besides eczema? Is it seborrheic dermatitis or bad dandruff? Is it allergic contact dermatitis, which I'll go into later, because kids almost just as often as adults can get allergic contact dermatitis as well. There's also a rare condition called autoimmune progesterone dermatitis, which we'll see in menstruating women that right around the time of their period, they'll literally have increased allergic responses. So every 3 to 4 weeks, like clockwork, they can have hives, itching, eczema flaring, and in rare cases, even anaphylaxis. And probably about several times a year, I'll pick up one of those cases as well. For really severe cases in infancy, especially if they have a lot of swollen lymph nodes, there's also cases of immune deficiency, where they present with severe eczema and then they start to get severe infections. So with very severe eczema cases in infants, it's important to check a blood count, look at their lymphocytes, look at what's called immunoglobulins as well, because if those are very low, then you have to think of immune deficiencies and other critical treatments, especially in those first few months. Tinea or fungal infections are very important to make sure you don't miss as well. A lot of fungal infections can be scaling, just like eczema. And especially in infants with a lot of folds in their skin and drooling and teething and increased moisture, fungal infections can be a big problem. There's an autoimmune skin condition called, and also affects your muscles, called dermatomyositis. And if patients are often very tired and have a hard time with activities of daily living, such as even brushing their hair, climbing the stairs, and if they have certain rashes and certain distributions, it could be this condition. Drug reactions are a big factor. We'll see cases where all the tests seem to be normal and patients can be on the same drug for years at a time, even decades at a time. And it turns out it's a medication reaction. And it can be very common medications that people take, and cholesterol med, a vitamin supplement. There are cases of psoriasis that can even look like eczema. Although psoriasis tends to have very silvery scales, it can be in plaques, it tends to affect the elbows rather than flexural areas. Scabies can be a very tricky one. I've had cases where couples sleeping together, one person will have it, the other person will not. And that can be extremely deceiving because one would think, well, geez, both should get it, but we've seen some scabies cases where only one got it and the other one didn't. So that's an important thing to always think about, especially when people are really itchy at night. It's along the belt line, it's in between the fingers. They've moved into a new home, for example, or they recently traveled. Sometimes that can be missed by multiple providers. Also, metabolic conditions, say zinc deficiency, vitamin D deficiency. There's also less common conditions called Netherton syndrome, where your skin can get very scaly, almost looking like fish scales. And sadly, also some cancerous conditions as well, such as Langerhans histiocytosis X, and for older adults, cutaneous T-cell lymphoma. So if you have an adult in their 70s that suddenly presents with severe eczema, it's really important they get a skin biopsy. And sometimes it takes multiple skin biopsies to pick this up. So other causes of itching too. People could have autoimmune blistering reactions, neurologic causes, multiple sclerosis. Shingles can present with a lot of itching for a while before it starts to become painful. Certain infections can make you itch. Liver conditions, thyroid conditions, kidney conditions, certain substance abuse conditions can also, but with opiates, can make one very itchy as well. Um, and sometimes for psychological conditions, we'll see that as well. But that importantly has to be a diagnosis of exclusion, and other causes have to be ruled out. So the aggravators of eczema, especially when moisturizing and topical anti-inflammatory measures such as topical steroids are not enough, it's always important to think, well, what's making this worse when we think it's eczema. So detergents, fabrics, especially uniforms at work. I've taken care of patients in law enforcement, paramedics, firefighters, where just their uniform can be particularly harsh. The dyes in their uniforms can be an issue. Sweating, excessive sweating can be a big issue. Stress can be a huge factor. Stress is brutal on all of our immune systems, so that can definitely flare eczema. Again, back to infections, staph being a big one. And allergic sensitization, environmental allergies, food allergies, contact allergens. So for staph, well, why does staph cause such problems? Well, staph in the skin actually makes a hyperimmune response in the skin, which activates T cells, and you can actually make antibodies directed against staph as well, IgE, almost allergic antibodies against it. So in cases of staph infection, they almost become steroid resistant. So when the topical steroids are not working and the eczema appears angry and irritated, think staph infection. Um, so some of our toughest cases, one of the first things we do is we culture the skin, we culture the nose, and we culture the nose because people often carry staph in their nasal passages. And we all tend to touch our face hundreds of times a day. We'll rub our nose, especially if we have allergies, our nose itches. And then so just by literally touching their nose, touching their skin, they constantly reinfect themselves, recolonize themselves. So if you do find, say, MRSA on the skin, it's important to not only treat that infection on the skin, but consider trying to get rid of nasal colonization as well. So for environmental allergens and eczema, well, dust mite is a very big one, especially that's been recognized in the dermatology literature, and of course the allergy literature as well. But it could be pollens, dust mite, pet dander as well. So my toughest cases in my career, sadly, I've been linked to pet dander exposures. Remember one of my cases in my first year of fellowship at Children's. Parents hadn't slept in a couple weeks. Child age 5 had refused to put on clothes at that point. She was so uncomfortable, so we had to admit her to the hospital. And after 2 weeks of trying to figure out what's wrong, it turns out it was the family dog. Fortunately, there were relatives close by that could take the pet, so everyone could still see the pet. But about a month after the pet was out of the house, she was completely clear, completely basically back to normal. And everyone was sleeping through the night and she wasn't scratching again, but literally just being sensitive to the dog pushed her to that point. It was a tough case, but that was 99% the trigger. So with environmental controls, the main components are getting rid of clutter, which can be easier said than done. Dust mite proof mattress and pillow covers, air purification, washing the sheets weekly in hot water, especially for dust mite avoidance. Having people find a new home for pets is 99.999% it won't happen. And, being a pet owner myself, I totally get that. Pets become like family members, and for most of us as allergists, we're very understanding about that at this point. Situations like the one I just mentioned for that eczema case, there are going to be exceptions when there's sadly no choice. But at least getting the pets out of the bedroom, getting the pets off the bed can be helpful. Getting rid of carpets, I think, can make a big difference, especially with dust mite and pet dander allergy, especially in the bedroom. Trying to keep the windows closed, keeping the home at the right humidity level, 40% is ideal. Now for food allergy, when people think food allergy, of course, thing we all worry about the most is anaphylaxis. But there's a whole spectrum. I mean, you could have intolerances, and even within the range of anaphylaxis, there's very mild allergic reactions such as oral allergy syndrome, where patients are allergic to birch pollen, for example. And if they eat an apple, which is biologically similar to birch, like a raw apple, they'll get an itchy mouth. And 90+% of the time, it doesn't get worse. Sometimes allergies can also make hives worse. Although a lot of hives can be more of an excessive immune response, like an autoimmune response rather than allergy. We do see cases where allergies can be indeed a trigger for hives. And then of course there's anaphylaxis, the food reaction that we all worry the most about. And then you can have a mixed picture where in eczema, they can have immediate reactions, they can have delayed reactions. And in food sensitivities, it can also trigger asthma, it can even in some cases trigger a runny nose. There's also a condition where you almost get like eczema of your esophagus or parts of your intestinal tract, and that's called eosinophilic esophagitis or eosinophilic gastroenteritis. And those gastrointestinal cases are being recognized more and more, not only in kids, but adults. And they were first discovered in the 90s, and I think more and more cases are being recognized and picked up. And then there's even cases that are mainly manifest in infants and toddlers where they're fortunately often outgrown, but they won't even be picked up in allergy testing, and they'll have severe GI reactions with extreme vomiting and diarrhea, and then it'll resolve in a couple hours, and they won't even show up in allergy testing because it's not an IgE mediated response. Then there's also celiac disease, which is an autoimmune response at the level of the gastrointestinal tract. And there's even a version of celiac disease called dermatitis herpetiformis that can present like severe eczema, but once you go on a gluten-free diet, that tends to resolve as well. So with food allergy and eczema, with my colleagues in dermatology, we sometimes agree to disagree on this, where in the allergy literature, some of my papers say up to 1 in 3 patients with moderate to severe eczema, foods can definitely be a trigger. There is some current thinking where we want to try not to blame the foods because we don't want to overly restrict people's diet, but there are indeed cases where foods inevitably are a significant trigger. So I still believe in checking for this, but I also very much believe in doing as many challenges possible to not overly restrict people's diets, because with the nature of eczema and one's skin being so reactive and one's immune system being so reactive, it's very easy when you screen for food allergy with a patient with eczema to get a lot of positive tests, and interpretation of those tests is very critical so that you don't get into trouble for overdiagnosing eczema. Or not overdiagnosing, for overdiagnosing food allergy. And we see this a lot, especially if people are birch allergic plus have eczema. It can overdiagnose peanut allergy, for example, and you can get into trouble where the diet can be extremely limited, and then you can risk malnutrition. So doing food challenges and really testing the test results is extremely important. I can pause now because I just went through a ton of information, but are there any questions at this time?
Dr. Scott, there is one question in the
Sure.
chat from
Yeah.
Joan.
Yeah. Hi, Joan.
Joan, I don't know if you want to unmute. I'd be happy to ask the question for you. Joan is asking, is there a connection of eczema to psoriasis?
Good question. They're technically different pathological processes. They're both hyperimmune response, so they're both T cell mediated. And in psoriasis, you'll get an excess of skin cell production, where with eczema, it's in excess of inflammatory mediators to the skin causing excessive itching and skin breakdown. So they are different inflammatory processes, but we will see a number of patients when they just have overactive immune systems that they'll have both conditions, which can make things very tricky, because sometimes the both conditions will look alike, and then they'll have 2 separate skin processes at the same time. And then, although topical steroids can be used to treat both, when those conditions get more severe, there's different types of biologics where, for example, Dupixent is really good for eczema. And then there's other biologics for psoriasis where Dupixent, for example, would not be helpful. So yeah, this is where the role of sometimes skin biopsies are really needed to tell things apart.
Thank you.
Sure.
That's the only question at the moment, Dr. Scott.
Oh, sure. Okay. All right. So we'll keep moving on. So let's see. And and also for food allergies, 90% of the time, if it's a food allergy, it's going to be milk, egg, wheat, soy, peanuts, nuts, fish. Sesame now has become one of the more common allergens as well. And also, when we're testing these test results, you need to look at patterns that continue to repeat themselves. If on a repeated basis, when there's dairy consumption and there's flaring of eczema and there's a positive test, then very likely and indeed is it's a truly relevant food. So again, this is, I briefly covered this before, but these are medicines associated with itching, opiates, blood pressure meds. I've seen, unfortunately, a lot of problems with lisinopril. It's a great blood pressure med, but in the allergy literature, we can see cough as a side effect, angioedema, which is another way to describe recurring swelling. Some of my toughest urticaria or hive cases where nobody can figure out what's causing the hives. It's actually been related to lisinopril. So if I have a patient coming with severe allergies on lisinopril, if nothing else is working, one important thought is to discontinue the lisinopril or find an alternative blood pressure med. And we definitely see cases where things get better. Non-steroidal anti-inflammatories is another sneaky one. We always make it a point to ask about them because sometimes people won't think to label them as their routine medicines because a lot of them you can get over the counter. So always an important thing to ask about because these drugs could also be associated with hives, swelling, and itching. Medicines for gout as well, a lot of them are non-steroidals, anti-inflammatory drugs as well. Cholesterol meds, a lot of the generic ones in particular that we see routinely used, simvastatin, pravastatin. We've picked those up with skin reactions as well. Even reflux meds as well. A lot of them routinely available over the counter. What's tough is I'll use Pepcid, for example, a stomach acid med to control hives because it also helps to block histamine. But this same med can also have a side effect of itching. Hydroxychloroquine could be another one used for rheumatoid arthritis. Hormone replacement therapies can also be another sneaky one, and those include oral contraceptives, for example, or testosterone replacement therapy. I mean, two very common medicines also can be associated with itching. So for the most common contact allergens, and this was from a few years back, but this list is frequently updated. Propylene glycol is now a recent one that you could argue should be on here as well. And some of these things can be in processed foods, salad dressings. Nickel is a particular tricky one because it's not only in jewelry but in zippers and cell phones, Fitbits, iWatches, belt buckles. It can naturally occur in foods, for example, spinach, chocolate, coffee, canned goods. It can be a tricky one to avoid. And, whenever a patient's diagnosed with severe nickel contact dermatitis, I always make it a point to tell them I do not expect you to 100% strictly avoid this because it is just everywhere in our society. But as much as they can be aware of it and try to limit it, we can get some very significant improvement in their skin. Fragrance mix is another sneaky one. Basically, any personal care product that smells good pretty much uses fragrance mix. This MCI or MI also goes under the name chloroisothiazolazone. That's a hard one to say despite all my years of practice. And these are often preservatives used to keep things lasting on the shelf for years at a time. PPD or paraphenyl is used in a lot of hair dyes. So we'll see people after going to the hair salon or dyeing their hair, they'll have horrible scalp dermatitis, horrible facial dermatitis, and it'll last for months because the hair dye will last for months. Formaldehyde's a really sneaky one, and one may think, well, where the heck am I being exposed to formaldehyde? They throw it in clothing. They throw it in clothing tags. They throw it in makeup. They can throw it in shampoos, other personal care products. And again, well, it's a preservative. It keeps things lasting longer. Formaldehyde can also prevent clothing from wrinkling. So some of those wrinkle-resistant shirts or uniforms I was mentioning when I saw people, especially first responders, having horrible reactions to their uniforms. Sometimes it could be formaldehyde related, not just clothing dye related. Lanolin, from sheep, basically. They throw that in Aquaphor, a lot of brands of Aquaphor, which is a real common moisturizer, which for a lot of patients is very effective. But we'll see some patients who come in and we'll get the story, well, all the moisturizers make them worse, and very likely they're allergic to lanolin. Glycosyl, also known as idylpropylbutyl carbamate. Oh, it's a mouthful. That one's used in a lot of wipes. So all those baby wipes, wet ones, all those cleaning products that I know. And when my now teenagers were a lot younger, we used wipes constantly, loaded with contact allergens. Um, and a very important point is allergic contact dermatitis is so often underdiagnosed in children. So for a lot of difficult to control eczema cases, we are starting to patch test more in kids because we've seen cases where they can even be allergic to medicines such as steroids. I had one case years back. It was presented at dermatology grand rounds, I think in the Harvard system. I think I was opinion 8. And I remember they had seen people that I had done rotations with. And I was thinking, well, how am I going to help? And I figured, all right, well, I think everyone's done everything except patch test. So we patch tested this poor child who had a facial dermatitis that just would not go away. And it turns out this child was allergic to topical steroids. So as soon as we stopped treating with the topical steroids, which everyone was giving this child, within a week or 2, the eczema was completely gone. So for all those years of suffering, it turns out the child was allergic to topical steroids. So again, despite sometimes our best intentions, it's always important to think of drug side effects. So onto the treatment of eczema. The basics will always be moisturizing and anti-inflammatory agents. The Atopic Dermatitis Center at Boston Children's Hospital, I think, does a really good job just with these 2 basics, just reinforcing the importance of sticking to this and getting to a really good regimen to use on a routine basis. And doing this is honestly easier said than done. I mean, when both my children, when they were infants and toddlers, had some, pretty moderate eczema, especially my oldest, Abby, it was a good lesson to how often you actually have to moisturize to stay ahead of this. I mean, we're talking 5, 6, sometimes 7 times a day. You could argue almost with every diaper change, sometimes to really stay on top of their skin if it's very dry. So keeping the skin well hydrated is critical. And also with the anti-inflammatory agents, to not be afraid of topical steroids, to use them in moderate amounts. Doesn't mean you have to cover somebody head to toe with them. I definitely wouldn't recommend that. But often people are really afraid to use them even in moderate amounts because they'll think even a moderate to small amount is too much. And then if they never use them, it flares to the point where you have to end up using a significant amount. So years back, they did this study in one of the dermatology journals where they actually measured the amount of steroids that a patient needed if they did either a reactive approach versus a preventative approach. And they found that when people started the steroids early, like you see a patch of eczema and you're like, all right, here it comes, and I'm going to treat this early. Those patients use so much less topical steroid than the ones who waited until it was really bad and then they had to play catch up to get it under control. So hitting it quickly, early, using the steroids maybe a little more frequently, but still not a lot in large amounts, you can stay so much more ahead of it. And then in terms, I'm often asked as well, what brand of moisturizer should I use? I mean, it's really, there, I can recommend numerous brands, but I find, it's very patient specific. Over the years, I can think of dozens of brands that have worked for various patients. You want to be sure for some patients, it may, if it's too goopy or greasy, they may not want to use it, but some people don't mind if it's goopy or greasy. It definitely has to be affordable. Obviously they can't be allergic to it like lanolin, but I guess I've always learned just to keep your mind open about multiple brands of moisturizers. And then also with the steroids, we try to not go there with oral steroids. There are some cases where I've had to do oral steroid tapers, but you really rather not, because as soon as you put someone on an oral taper, as soon as you stop it, it tends to rebound with a vengeance, and you can get into a vicious cycle where you keep needing oral steroids. There are cases when it's so severe we need it to catch up for the topical meds to start working, but we try to very, very, very rarely do that. So also with bathing, this is another very important factor. It's often taught in a lot of primary care residencies, oh, you shouldn't bathe. Bathing dries out the skin. So bathe the least amount possible. But, I'd say as long as you could bathe every day, frankly, as long as you're hydrating the skin right afterwards and you're not taking, say, too hot a shower, which would dry out the skin. So as long as you're lukewarm water, soaking and sealing in the tub, or taking a nice shower for a few minutes, and then patting the skin dry gently, and then moisturizing right afterwards, you're going to ensure some really good skin hydration. And then we see some cases, especially with the kids, where their skin is so raw it literally hurts them to bathe. So Carol Timmons, a longtime nurse practitioner in the Eczema Center at Boston Children's, thing she taught me in fellowship was have the kids jump in the tub with their clothes on, which I know it's wild, but it works. Just the act of their clothes on helps them get through the pain of their skin being raw when they're in the tub. Wet wraps we're a big fan of, where literally you take these moist dressings and you wrap their skin, especially to the raw areas. Bleach baths. This is going to sound completely insane, but it's very effective in getting rid of staph colonization. You take 1/3 cup of Clorox in a tub full of water, and it helps. It's like pool water at that point, and it gets rid of staph. Cutting nails is important, so they're not scratching their skin raw. Loose fitting cotton clothing is important, and again, getting rid of staph as much as possible. Again, with the environmental controls, we had touched upon this before. My pet dander story, some of the toughest cases possible. We have to address the issues with the pet. With the food avoidance strategies, not only look at the positive test results, but are they clinically relevant? And with patch testing for contact allergens, it's not just adults, think kids as well. Some of the newer topical meds that have been out for the last few years, there's one called Eucrisa. It's a phosphodiesterase inhibitor. It's another way to block an inflammatory pathway in eczema. What's nice is it's a non-steroid. So you can use it on the face. You can use it on other sensitive skin areas where we tend to not like to use topical steroids. And then there's also been the topical calcineurin inhibitors, such as tacrolimus, pimecrolimus, and those have been out for quite a while now. One thing that's important to mention is the topical calcineurin inhibitors will have a black box warning. What's important to know about that warning is that when that came out, the dermatologists and allergists were really, really disappointed that that was even considered an issue, simply because in mice, 9 times the maximum human dose, if you give these topical meds for 6 months straight, some mice develop cancer. Now, when they looked at people who got these meds compared to the general population, there was no difference in malignancies. So the take-home message from that is like, don't bathe yourself in it head to toe for 6 months straight, but no one would. So you can use it in moderate amounts as needed. You should be fine. I've had family members that have used it. I personally will be comfortable using it in moderate amounts as needed. I think these are very good meds, especially if you want to not have to use topical steroids in sensitive areas such as the face. So I think they are safe to use, but I always give patients a heads up about that black box warning, because it's very disconcerting if you don't know about that warning and you're seeing it for the first time when you pick up the medicine. Now, for that medicine, though, the topical calcineurin inhibitors, if you happen to have a skin infection history, like say herpes in the skin or eczema or pedicum, you do want to hold off on this medicine, because that type of medicine can worsen those types of viral skin infections. Now, for severe eczema treatments, when you have to admit to the hospital, again, it's all about skin infection. So if your skin's bright red all over, there's oozing, there's weeping, there's pus, fevers, those severe sleep deprivation where literally families can't even function, those are the times when we would admit to the hospital. So other adjunctive treatments we use to help decrease itching, well, antihistamines, which, have limited benefit. I mean, they can help to some degree, but, for those strong antihistamines, mainly help people sleep through the night, such as Atarax or Benadryl. Allergy shots as well, a big thing, a big treatment that allergists will give, especially to cover dust mite, mold, pollen, and pet dander. Xolair or omalizumab, it was initially approved for difficult to control asthma. It's been a great medicine for difficult to control asthma. It's also approved for difficult to control hives. And we found over the years, while treating our severe asthmatics with who happen to have moderate to severe eczema, for a lot of them it helped their eczema too. So for a little bit before some other medicines came out, one of the side effect benefits of the Xolair was it would help with eczema. Now, keep in mind, Xolair's not FDA approved to help with eczema, but I have used it personally, and I have no other colleagues that have used it in cases of severe eczema over the years. There's also now a medicine called dupilumab, also known as Dupixent, which blocks some other allergic pathways. That's been approved over the last few years for very severe eczema, and that's been extremely effective. So now basically we have more monoclonal antibody therapies for really tough eczema cases. There's also one that's going to be coming out as an anti-itch that's actually used in veterinary medicine, but it's hopefully will be approved for humans soon. So by decreasing itching, that's going to be game changing as well. For various supplements, fish oil supplementation, probiotics, for some cases that can be extremely helpful for eczema. Vitamin D supplementation may actually help your ability to fight staph in the skin. Phototherapy, our dermatology colleagues have been using that for decades in severe eczema cases. You can also even use cyclosporin and methotrexate, which are, medicine used in cancer, but because they're such strong immune suppressants with numerous side effects, we only extreme cases like to use those, and for a very short-term period of time. Stress management is extremely important, adequate sleep, psychological interventions as well to help, coping with itching and the stress of dealing with this chronic medical condition too. So for allergy shots, could it be helpful for eczema? Well, it's mainly used for allergic asthma, nasal allergies, bee sting allergies as well. And it takes several years to get someone desensitized long-term, but there are articles out there that it can also help for difficult to control eczema, especially when somebody has multiple environmental allergens, in particular dust mite allergy. And we also now, if for people who can, have a hard time, say, getting shots or too busy to come to the doctor's office to get shots, there's also sublingual immune therapy where we can do tablets under the tongue, drops under the tongue. So there are other ways to now desensitize without having to give injections. So by desensitizing to those allergens, we can also help people's eczema. So actually, we covered that with the Xolair for atopic dermatitis. And back to this Dupixent. So it blocks IL-4 and IL-13. These are two cytokines which are strongly involved in the allergic inflammation for eczema. And they've now gotten approved ages 6 years and above for severe eczema. And again, it has to be quite severe, and to get it covered by insurance, other topical measures have to be tried, sometimes other oral measures, including oral steroids. There's some insurance companies that even require you to try cyclosporin or methotrexate too. For side effects, I have seen conjunctivitis, local skin reactions, very rarely medication reactions such as anaphylaxis, but that's extremely rare. What's nice about the Dupixent is it can be given at home. We do have some patients that are just too uncomfortable to get it at home, so we'll give it in our practices, but majority of patients can be taught to give it at home, no problem. And Dupixent can also be used for nasal polyps, difficult to control asthma, and they're looking into using Dupixent for also that condition, eosinophilic esophagitis, where people get inflammation in their esophagus from allergies as well. So in conclusion, all these tools, triggers, aspects of the differential diagnosis to look out for in severe eczema, think about them when the moisturizing and anti-inflammatory agents aren't enough to treat the eczema. And for the aggravators, think of irritants and allergens and sweat, stress, infections. And then also a very important point, it may look like eczema, but is it eczema? And are there other comorbid conditions that could be contributing? So I just want to be sure I left plenty of time for questions. And thank you all for your time.
Great, Dr. Scott. The next question is from Cassie. Cassie, I don't know if you want to unmute and ask Dr. Scott your question.
Yes. Can you hear me?
I can. Hi.
Hi. I have two little boys that both have allergies, eczema, food allergies, you name it. We're a family of food warriors at our house. And we've been to so many dermatologists and everything. And I guess the treatment kind of changes depending on who I see.
Mm-hmm.
The most recent, we are doing bleach baths.
Yep.
The dermatologist did tell us to do bleach baths like 5 times a week. I am not sure if that is a lot. It seems a little excessive. But I just wanted to see your opinion on like how many baths, not baths, how many bath days. I know everything depends on each individual patient, but what is the average?
Yeah, so I mean, the average could be once to twice a week, but I'd say, if somebody is chronically colonized and has a lot of problems with recurring staph, I could see doing 5 days a week, which would kind of be the equivalent of swimming in pool water, if you look at it that way, especially if it's diluted enough. Did the dermatologist say for how long to do it?
They just said that would be like his regimen. That it wasn't for a limited time. And he is a scratcher to begin with, so he does get. We've had impetigo twice, and he's 6. So we, as soon as I see it coming on, we're like, bath time, let's go.
Yeah.
We're outside now, so every time we go outside, that means we have to go home and take a good bath because we can't do grass.
Yeah. Oh. And so I mean, I would look at it as almost like, swimming in, especially if it's dilute enough, it's just like swimming in pool water.
Okay.
Now, have they cultured the skin as well? Like, do we know
I'm
what
not
type of
sure.
staph you're dealing with?
No, I'm not sure. And that's whenever that was one of your points on here. I'm going to ask. I honestly don't know. How do they do that? They would just do like a nose swab?
Yeah, so it's sort of like a Q-tip. You could swab like just right. Sorry, pick my nose here. it's right just right around the outer aspect of the nose.
Okay.
And then I often take the most aggressive angry looking, upset lesion. It's like, all right, what's the part that they're really digging at? And then that's the area I'll culture as well.
Okay. Yeah, I'm sure over the last 7 years between both kids, someone did that somewhere, but I definitely we have a new appointment in June, so I'll make sure I ask some of those questions.
Yeah. And then there is some controversy about treating the colonization, because there's some infectious disease folks that'll say, all right, you could do the Bactroban nasally, first 5 days of the month for several months. And then some people, if it's, if the skin's bad enough, they'll put them on a 2-week course of antibiotics. I've done that before, and it's really helped get rid of it. Especially when there's colonization. Some people will say, well, there's colonization, there's not infection. Do we really necessarily treat? But if it's been that tough and chronic, a 2-week course of antibiotics, especially when someone hasn't been on antibiotics a lot, I think is reasonable,
Yeah. Right now, our main thing is, of course, moisturize, like you say. In between, we do a steroid in areas as needed for like a week to 2 weeks. And then in between, like over the counter, we have a whole area dedicated to medicines and stuff. So people come over, they think we're weirdos. We're like, don't worry, we're used to it by now.
Yeah, and then the other thing to consider, I mean, another point I mentioned in the talk is it worthwhile, because derm and allergy both do this test. Is it worthwhile doing patch testing? Like, could one of the personal care products be making this so hard to control and flaring stuff? You know, could it be even one of the products we're using that we think is helpful? Hey, buddy.
This is one of my allergy warriors here. We're outside playing.
Hi.
Hi. All right, go baby. Thank you so much.
No, not a problem.
Thank you, Cassie. Dr. Scott, you have two more questions. The
Sure.
next one is from Adelina. She has a question regarding additional strategies to try for her daughter's eczema,
Mhm.
which seems to be triggered by heat and often impacts her quality of sleep during the warmer months. She moisturizes with Aquaphor every day and uses a steroid cream when needed and takes Zyrtec on very itchy days. And Adelina, please feel free to unmute if you would like to.
Hi, can you hear me?
I
This is
can. Hi
Adelina.
there.
Hi. That's pretty much all. I mean, it's an extensive question, but yeah, she's just struggled. We've seen dermatologists, but it's just something that she hasn't had really completely under control. And it's just on the days where she's just not sleeping well. We're just concerned. She's a young adult now, and sleep's really important for the teen and
No, absolutely.
college age. Yeah.
For air conditioning, what's the air conditioning situation like for?
Oh, well, at home we have central air
Nice.
upstairs, although it doesn't get super cold. It's probably in the mid to upper 70s, but she's like off in college now. Actually, she's in her own apartment, and she's in LA, which is drier weather, but it's still usually still warm. And I think in her apartment this year, she does not have an air conditioning unit. So it may get warm, I think, in her room.
That I'm wondering could be some of it, especially with the heat. And then for the Aquaphor, has that been out of all the moisturizers she's tried over the years, has that been the most effective one for her, or has she tried other brands?
She hasn't tried too many other brands. I think I tried. I don't know if it's just kind of the one that our doctors have told us, and
Yeah.
she's just kind of stuck with it. We haven't really. Are there other moisturizers you think she should try?
Yeah, so I like CeraVe because it as a lotion, it's not as goopy, and it has ceramides in it, so it can decrease water loss from the skin. I'm not paid by CeraVe, I swear, but what I like is that it's again, it's not as goopy, because some of the goopy, greasy ones, especially as patients get older, they're just hard to deal with applying every day. If they stain the clothes or they stain the sheets, they can be hard to deal with on a routine basis. And when you really start to ask patients, sometimes they'll admit, they're like, yeah, I don't do this as much as I should. I mean, for my own children, we've had that issue too. And when we've switched to the lotions that absorb a bit faster and don't have that lingering goopy, greasy feeling, there we tend to get more compliant. So CeraVe could definitely be one thing we could try.
Okay, great.
That's
Thank you.
CERAVE.
Yep. Okay, I got it. Great. Thank you.
Sure.
Thank you, Adelina. Two more questions, Dr. Scott. Sharon asks, is topical steroid cream available over the counter? And is it helpful to use for mild but chronic AD on the hand? What percentage to look for? How often to use for an adult? And Sharon, please.
Yeah, sure. Hi there. Hi, Sharon. So for the topical steroids, the strongest that's usually available over the counter that I've seen is 1%. The hands tend to be thicker skinned areas. So if you find that the 1% twice a day for up to say 2 weeks, it's still not getting better, then you may need a prescription strength. And the lowest of prescription strength tend to be 2.5% for hydrocortisone and then above. And then there's many different brands of various potencies in the prescriptions that can go stronger and stronger if needed. But yeah, for the over-the-counter options, 1% if it's mild should be okay, but you may need to use it for a few days. And hands are tricky because we're constantly washing them, so there's constant irritations from soaps and detergents, and they just have constant exposure to everything in our environment. So yeah, they don't get a break.
Great, thank you. The last question right now is again from Joan. My understanding is that testing for children's allergies is the same as what I have experienced, needles, scratch tests. Do you know if research is being done for alternative testing methods for children? It's hard to expect a 4-year-old to sit through this. Thank you.
Yeah, hi, Joan.
Hi, Dr. Scott.
All right. So for the kids, yes, similar technique, but we tend to group the allergens a bit together for the kids. So, instead of the individual trees, we'll do a tree mix. Instead of different species of grasses, we'll do a grass mix. So we'll use less of them. And then we'll also do the multi-tests where for a lot of allergists, when I started out in practice too, we did the individual scratches. But now with the multi-tests going on in groups of 10 or 8, it's gotten a lot faster and kinder and gentler over the years. So we see a lot of kids as young as, several months old. And yeah, I'll admit that they'll be a little upset and startled when we put it on, but literally in several seconds, we'll have the test on. 15 minutes, we'll have it read. And my own kids have had it done when they were younger. Although my youngest daughter, Charlotte, did say to me at age 5, she said, "Dad, I can't believe you do that to people." Which I was like, "Yes, Charlotte, I know." But in fairness, I've had people practice on me to learn how to do it. It is annoying. It's a bit itchy, absolutely. But I think with a multi-test grouping allergens together, we can do it. That's a little kinder, gentler for kids, at least with the current strategies. They are definitely working on some newer technologies. There are a lot of startups out there where they're looking at ways to not do it by blood or by pricking the skin. Something as simple as just placing on the skin and looking at responses. And stay tuned for that in a few years. There's definitely going to be some more technologies coming out. I think what's going to be tricky is comparing them to standards and sensitivity and specificity. And with anything new, there's going to be some resistance to change because change just takes time for everybody. But yeah, if there are ways we can make this easier for people to get the diagnosis, I'm all for it. Absolutely.
Yeah.
We do have some people that need to come in. They're just so nervous,
Yeah.
and it's hard. Yeah.
Yeah. Well, that's encouraging. Thank you very much, Dr. Scott.
Thank you, Joan. And just a comment from Cassie. She said both of her children were 12 months old and they've had roughly 3 tests so far. So,
Yeah.
So thank you everybody for all of the questions. I'm very glad we had time. It's actually 7:58, so that really worked out perfectly. So I just again want to thank Dr. Scott. This was, an excellent event. I really appreciate your time, and
Sure.
and I learned quite a bit. Thank you to everybody who attended. Thank you again to GlaxoSmithKline, who sponsors our speaker series events. I just want to mention that we do have one more talk in our spring series, and that is going to be on June 8th, Tuesday at 7 p.m. with Dr. Chris Olson. She's the co-founder and executive chair of the Food Allergy Science Institute, FASI for short. She's going to be giving an overview of her organization and then speaking on the role played by interactions between foods, the gut, the brain, and the nervous system. So that's June 8th. And I just encourage you to go to asthmaandallergies.org to sign up for that event and any others. Join our mailing list, become a member, or to make a donation to AFA New England. Your support makes possible our pursuit of life without limits for people and their families affected by asthma and allergy conditions. So thank you all. Thank you, Dr. Scott. I hope everyone has a nice evening.
Thanks, everybody. Thanks for